It's a great pleasure now to hand over to the, in a way, the inspiration behind this panel, which is Norfolk GP and menopause expert Susanne Markham.
Hello. Hi, my name is Dr. Susanne Ahlund, and it's really great to see you all here today wanting to learn more about the menopause, including a few men, because menopause really is everyone's business. We strongly believe that increased knowledge will help empower women and an increased understanding of what's going to happen in our lives at this time, and inevitably it will happen to all women, will help empower women to feel that they can come and ask for advice, seek support, and not feel worried and fear the symptoms that they're going through, and know that there is help there. Sometimes women, or possibly their partners, their employers, maybe even their children, or even their doctor, may not realise that the struggles that they're going through are to do with changing hormone levels. Or it may be that they do realise that that is the problem, and that they seek help but find that they're struggling to get the right help at that point. It may even be that they find themselves in a crisis at that point in life. They might go through a relationship breakdown. They might feel they have to leave the job they've always loved to do. Or they might find that they're being bounced around to different hospital specialties with different disabling symptoms, and that no one's able to join the dots up, or even that they're tried on different treatments that doesn't really work, and not really getting to the core of the problem. So why are we not better at joining up the dots, and why are we not better at managing this time in a woman's life better? So I'm really pleased to say that we've got an expert panel here today with me that will help us explore some of those biggest myths around HRT and menopause. And it would be great if you could all say a few words about yourselves.
Yeah, so I'm Hannah Healy. I'm a GP in the city in Norwich, and I've got a special interest in menopause care.
I'm Emily Cary. I'm also a GP at Mattershall Surgery, and like Hannah and Susanne, I've done a lot of specialist menopause training recently to really upskill myself, and I've enjoyed that immensely.
Hi everyone, I'm Tim Duncan. I'm a consultant gynaecologist at the Norwich Hospital, and it's great to share a stage with GPs to really get a link between secondary care and primary care for this important subject. So thank you all for coming.
And I'm Paul Simpson. I also work at the Norfolk and Norwich with Tim as one of the gynaecologists. I'm involved in the menopause clinic that we run at the Norfolk and Norwich Hospital, and also part of the Medical Advisory Council for the British Menopause Society. So yeah, welcome everyone. What we're going to talk about is, I guess, a little bit of information, and then if any of you have questions at the end, we'll go through them. So, yeah, thank you.
So I was hoping for us to start off with a bit more background around what the menopause and the perimenopause is. Would you be happy to take that on, Hannah?
Absolutely.
And tell us a bit more?
Absolutely. So the menopause comes at a really difficult time of life. Women are often juggling a lot: teenage children, relationships, elderly parents, and they can also be at the pinnacle of their work career at this stage. So it's great that awareness in the media has increased, but there's still 50% of women don't seek advice from their healthcare professional at this time of life. And this is in the context of 4 out of 5 women having symptoms. So today we want to raise awareness so that women don't struggle in silence. A woman will spend a huge amount of time in the perimenopause and the postmenopausal state, so managing its effects is really important. It's important that women are given the correct information to empower them to make the right individual choices for them at this stage of life. So what is the menopause? Well, often women can think of it as the menopause transition, but the menopause is a specific point in, the medical definition for it is a specific point in time when your periods stop. And the accurate term for the time before and after this period is the perimenopause, and this is the transition or the gradual change from your reproductive years until 12 months after your last period. And for some women, the perimenopause can last just a few months, but for other women, it can last many years. And it's useful to have a look at what our hormones are doing at this stage of life to understand what's happening. So if you want to look at the slide here, you can see that first, so this is in a normal menstrual cycle, so prior to the menopause, your ovaries are producing 2 hormones, estrogen and progesterone. And you can see first you get rising levels of estrogen, which thicken the lining of the womb. And then you can see there's rising levels of progesterone, which prepare the lining of the womb for the fertilized egg. Now, if the egg isn't fertilized, the levels of estrogen and progesterone reduce, and the lining of the womb is shed, and that's what results in your period. So if we move to the next slide, in the menopause transition, the ovaries become less responsive, and the levels of estrogen and progesterone vary as a consequence. And these unpredictable hormone levels is what causes the symptoms of the perimenopause. And in addition, because of the changing levels in hormone levels, the lining of the womb can become thick and can shed chaotically, and this can lead to irregular, heavy periods for some individuals. So now I just wanted to mention about menopause symptoms, and the menopause symptoms are vast, and that's because there are estrogen receptors all over our bodies, and so declining levels of estrogen are going to have a myriad of symptoms affecting women in different ways, and affecting different systems. So what I have outlined already is what we would refer to as the natural menopause, which happens with advancing age. But it's important to be aware that the menopause can happen at other stages of life and in different situations. So there's a condition called primary ovarian insufficiency, which is when the menopause happens before the age of 40. And this affects 1% of women. And these individuals, it's particularly important to be aware of the emotional impact that the reduced fertility has, in the context of this diagnosis. And then there is the surgical menopause, which is when the ovaries are removed, and this can catapult a woman into the menopause, and so their symptoms can be much more severe. So in these two groups of women, it's particularly important that they get timely help and support, because it's really important that we manage their symptoms, but also it's important in terms of their long-term health outcomes that we replace these hormones. So how do we manage it? So I've just mentioned replacing the hormones. So HRT is the treatment of choice in the majority of women. And this is because the menopause is a deficiency state. And so just like with something like hypothyroidism, the best way to treat it is by replacing the hormones that you're deficient in. And for some, using hormones isn't an option, and non-hormonal treatments need to be looked into. And these can be things like antidepressants, colonidine, gabapentin, and pregabalin. But this is very much second line. And the menopause transition and the menopause is a time of life that is associated with increased cardiovascular disease and osteoporosis. And HRT can help with this, but it's also a key point in life where it's important to make lifestyle changes as well to try and manage those health risks attached to it. So in terms of explaining what HRT is, I like to break it down into the components of a cake, because it's a nice simplistic way of thinking about HRT, and who doesn't like cake? So the sponge represents the estrogen, and if you don't have a sponge, you don't have a cake. So the estrogen is that key ingredient that makes you feel better in yourself and is associated with those positive health outcomes. And then the jam represents the progesterone, and the progesterone is important to take. If you're taking estrogen and you have a womb, you need to take progesterone as a means of taking your HRT safely. If you have a womb and you don't take your progesterone, it can lead to unwanted changes in the lining of the womb. And so it's absolutely essential you take it if you do have a womb. And then not everybody likes or needs icing on their cake or a cherry on the top. And that's the same for vaginal estrogen and for testosterone. So the icing on the cake represents the vaginal estrogen, and this can be taken in addition to the main sponge estrogen. And it is there to keep the tissue in the vulva, the vagina, and the bladder healthy. And a lot of menopausal women suffer with dryness, irritation, and pain on sexual intercourse, and using estrogen locally in this way can really help. And then the cherry on the top, or the strawberry in the case of this cake, is testosterone, and this can be used for improving libido. So hopefully that's given you a succinct view on what the menopause is, what our hormones are doing during this time, and what we can do about it.
Thank you so much, Hannah. That's a really great introduction to the perimenopause and menopause. So Emily, I know you see a very large number of women in your GP clinic every week. Why do you think it is that we still miss making the diagnosis of perimenopause and menopause, and what consequences do you think this may have for women's health?
Yeah, thanks, Susanne. In your introduction, you've already alluded to the fact that we seem to find it really, really hard to pin down perimenopause. And I think there are mainly two reasons for this. Firstly, lack of knowledge and lack of education, and that's in the population as a whole, but even in health professionals. And secondly, that the symptoms can be so varied. It's not just hot flushes and period stopping. I don't want to overload anyone with facts and figures, but I do just want to point to a survey that was done by Newson Health back in 2021. This was a survey of around 1,000 women, and they found that for 30% of women, so almost 1 in 3, it took more than 3 years after the onset of their symptoms of perimenopause for them to get a diagnosis. And for 18%, so nearly 1 in 5 women, they saw a doctor or other health professional at least 6 times during that time. So it's really not surprising that women often get frustrated. After all, they're often desperate by the time they come and ask for help, and if they don't get the right advice, they might well feel shortchanged. So lack of education is a big problem, and it is changing, thankfully. You've already mentioned that it's much higher profile in the media recently, and there's also been a lot on telly, podcasts, famous women talking about their menopause problems, and in the main, we think that's a good thing. But we do need to think of education at all levels. So primary schools and secondary schools all have PHSE, sex education programs, and children learn about all sorts of things during these classes, but menopause and perimenopause aren't on that list. And that's a shame, because most school-age children will have a mum or an aunt or a grandma, someone close to them that's struggling with the perimenopause. And of course, those struggles can have a huge impact on family dynamics, and if children understood from an early age what was going on, it might well help that family. So we're very keen on trying to normalise those conversations from an early age. And it was great to see quite a few children coming along today to our stand in the forum. But also at medical schools, it's pretty surprising, but standard medical school education doesn't have a lot of detail about menopause. It's not even included in GP training programmes. And that's clearly quite worrying, because we're the first port of call, as we know, for a lot of women when they're struggling. So I'm a GP, Susanne and Hannah are GPs, and we've, in the last year or two, undertaken quite a lot of specialist training to really upskill ourselves. But this has been in our own time, at our own expense, and we've been delighted to do it, but not every GP will have that opportunity. And you might find that your own GP hasn't had the chance, or that it's not a particular interest of theirs. As Hannah's already said, menopause is your last menstrual period, and I think a common perception is that you start struggling with symptoms when that last period happens. But in fact, the perimenopause, so that time of hormonal fluctuation leading up to the last period, can be the time that's most difficult, and that can last for a few months in some women, but up to a decade in others. So rather than women struggling when their periods stop in their 50s, it's often actually much younger women, even in their late 30s isn't unusual, or all through their 40s. And there's not an easy test for the menopause. Women often come asking for a blood test, but it's not like underactive thyroid or diabetes, where a blood test can give you a straight yes or no answer. For most women, perimenopause is a clinical diagnosis, so it's made on the basis of their symptoms, their age, their period pattern. You might have heard of raised FSH blood tests being done, but that's mainly useful in much younger women, especially when we're thinking about premature menopause. We've already seen from those slides that hormones can fluctuate wildly in the perimenopause, so if you get a raised level of the FSH, it can be helpful, but more likely you'll get a normal level or even a low level, and that's really no help at all. And sometimes that can be used to falsely reassure women that their symptoms aren't hormone related.
Thank you, Emily. That makes it really clear why it can be so difficult to reach a diagnosis. Absolutely. And you mentioned symptoms. Could you tell us a little bit more about the symptoms?
Yeah, of course. So let's move on to the symptoms. And the reality, as you've already said, is that we have estrogen receptors literally all over our bodies. And perimenopause can cause a huge variety of symptoms. I can't think of a single symptom that you could come to me with as a GP that couldn't be related to perimenopause, but of course all these symptoms can also have other causes. And as GPs, we're often programmed to exclude cancer, that's driven into us. We don't want to miss cancer, of course we don't. But you might find yourself being sent off for tests to see specialists, and that's probably where the 18% of women having more than 6 appointments with specialists before their diagnosis comes from. And what we want to try and do is more look at clusters of symptoms together and think about how likely it is that they could be hormone related. So let's just group the symptoms. The first group, and probably the one that we think about most, is the vasomotor symptoms. So that's hot flushes and night sweats. And about 80% of women will have these. They're extremely common to some degree or another. And we've all got internal thermostats, and normally we can cope with small changes in temperature from room temperature, emotion, hot drinks, exercise. But in the perimenopause, we lose that thermoneutral zone, and even slight fluctuations in temperature can lead to shivering or sweating, and that can be very disruptive and can really impact on a woman's sleep. Then there are other physical symptoms, and there are lots of these. So it could be change in bowel habit, bloating, abdominal pain, worsening of pre-existing asthma, other breathing problems can be triggered, skin changes, hair changes, and poor sleep is really common, and that can be independent of night sweats. And you might find that a woman who's previously been a good sleeper, poor sleep is the first symptom that she notices. Then there's the genitourinary symptoms of the menopause. So our genital tracts and bladder are full of estrogen receptors, and fluctuations in estrogen and low estrogen levels can cause burning, itching, dryness, soreness, and in the urinary tract this can cause frequency of urination and recurrent urine infections. And the sad thing about these symptoms are that women often won't volunteer them, so we need to remember as health professionals to ask specifically about these symptoms. And also these genitourinary symptoms sometimes do get worse in the postmenopausal period. So decades after the menopause, they can still be troublesome and getting worse, whereas a lot of the other perimenopausal symptoms do in fact get better with time. And then there's psychological symptoms, and this is a huge, huge group of symptoms that's often, sadly, not recognised as being hormonally driven. So depression, anxiety, irritability, and these can be really detrimental to a woman's health, and of course that's topical in the media at the moment. Also, memory problems. It's not unusual for a woman to feel that she might even be getting an early dementia, and that's because the hippocampus is a part of our brain that stores and forms memories, and that's absolutely stock full of estrogen receptors. A lot of women can feel really overwhelmed, and that's a word we hear a lot from women, is that they just feel overwhelmed at this time in their life. They've been juggling busy lives, busy careers, they've got a lot on their plates, perhaps extended family worries as well, and they've been coping, and then suddenly they just feel they can't cope. And that's a very sad situation for a lot of women.
I know that doing the specialist menopause training has changed the way that I approach my consultations in general practice. What has been your experience with this, Emily?
Yeah, I think my approach has changed too, and I think we've all learnt that we need to sit back, really listen to a woman, to what she's telling us and what her problems are, and then get a bit of an overview of what's going on, rather than honing in on one individual symptom. As I've said, just think about clusters of symptoms and think about that in terms of her age, her lifestyle, what else is going on in her life, her menstrual history, and really try and build a picture. A menopause symptom score can be really useful, and there are several of those. We're developing one at Norfolk Menopause, but there are plenty out there already. And sometimes a trial of HRT can be beneficial, and that can really help clinch the diagnosis for some women.
That's fantastic, and really helps to clarify some of the most important background facts around the menopause. It would be great if we could now move on to think a bit more about the management side of things. As I'm sure you're aware, there's been many articles in the media that's created all sorts of scares around the use of HRT, for example. So let's see if we can get our experts to help us contextualise this risk And to help clarify things in even more detail, maybe ask the question, should HRT be made available to all women of a certain age? Tim, would you be happy to help shed some light on this?
Of course,
Thank you.
So in my other life, I'm a cancer surgeon as well, so I come at this from two different angles. But I think risk is extremely important when we talk about HRT, because it's been so disruptive to women's health over the last 15 or 20 years because of this preconception that HRT is dangerous. So we've got to strip it back and look at what we talk about when we talk about risk. And I'll give an example of something that happened to me outside of a menopause clinic, because when I was doing obstetrics, and I had a patient and her partner who came in, and they had a Down syndrome test result back, and I said, "You've got a high risk result." And they said, "That's terrible." And they said, "Well, what's the risk?" And I said, "Well, it's 1%. And they said, "Well, that's not high risk. That's 99 times out of 100, my baby's going to be fine." And I then realised that what I was doing was putting my assessment of risk onto them. And actually what we've got to do is come together and determine what we actually are talking about when we're talking about high risk and low risk. So I think we've got to contextualise things between us as clinicians and as women as to what risks there are, how accurate they are to that individual, and then putting that into context of what the symptoms are that someone's suffering with, and then you can come to some conclusions. So whenever we talk about risk and benefit with HRT, you've got to look at both factors, because if someone has got very few symptoms, then actually the risks might be too great for them to take HRT. Whereas with another woman who's got very debilitating symptoms, but has also got risk factors for HRT, and they may actually decide that they want to take it, because it's all about the benefits that you can get from the HRT compared with the potential risks that you're taking. So you have to individualise it. And of course, there are many health benefits from taking HRT, so not taking HRT will give risk as well. We know about heart disease, dementia, osteoporosis. These will give you risk in later life. So there are risks both ways, so we've got to look at it in a very balanced way. So I firmly believe in personalising care. We need to look at individual risk factors. We need to look at symptoms and severity of symptoms, and then come to some conclusions about whether HRT is going to be right for that person or not. And so I've put this short slide together to try and illustrate where the risks come from with HRT. And I did try and find a picture of risk, and this one has got a pointer that's pointing to medium to high. I want to find one that had a pointing to low, because I think that's where we should be with HRT. So breast cancer is number one. This is, when you talk about HRT, people talk about breast cancer immediately. So we're going to cover that in a bit more detail. Some of the other ones are easier to cover. Blood clots. Yes, HRT can increase your risk of blood clots, but it depends on your individual risks as well, because if your background risk of blood clots is very low, and you add in HRT, you're actually not changing risk by very much. And there are also ways around risk of blood clots using transdermal, so HRT through the skin can be very helpful. Keeping doses low can be helpful. And similarly for stroke, if you're at a very low risk of stroke and you take out HRT, yes, you will increase your risk of stroke slightly, but it's all relative to what your background risk is. So this is where we have to come down to an individualised approach to risk assessment. And of course, there are side effects with HRT. Often these side effects can be transient, so the first month or two you may get side effects, but they tend to settle. And often women worry that they've had problems with hormonal contraception in the past, and that they've had problems with estrogen and progesterone before. But when we're talking about HRT, we're talking about much lower doses of hormones. So you're much less likely to get hormonal side effects with HRT compared to hormonal contraception. I do just want to cover breast cancer in a bit more detail, though, because this is the one thing that prevents many women from taking HRT. Sorry, I could only find Daily Mail headlines, apologies. But HRT is constantly in the media, and it's quite disruptive. I can't think of any other medication that is in the media as much as HRT. And it's very damaging because, of course, if you're writing a newspaper article, you want shock value, you want scare tactics. That's how you sell newspapers. It's not particularly helpful when you're talking about the intricacies of risk with HRT. And one of the big problems we had is there were some big studies that were published in the early 2000s looking at risk with HRT. And their main conclusions were that it would give you breast cancer and heart disease and strokes. And so overnight, GPs stopped prescribing HRT and women stopped asking for it. And we are still trying to play catch-up from these legacy trials, which have now been re-looked at and have been shown to be quite inaccurate in their conclusions. But we're still trying to wrestle back public confidence and GP confidence in use of HRT because of these trials. And why were they inaccurate? Well, you look at the types of patients that were in these studies, and they were often women who were older, so in their 60s when they were starting HRT. The majority were overweight. A lot of them were smokers. So if you put all those factors together, that increases your risk of heart disease, stroke, and breast cancer without ever taking HRT. You then add in estrogen to that population, you're going to get a different result to if you treat younger women who are trying their best to be fit and active and hopefully avoid smoking. So the population they were looking at is different to the population that we now prescribe HRT for. If you then look at the HRT that was being prescribed, quite high doses, and using certain progesterones that we would now consider to be the more risky progesterones. So it gets quite complicated because HRT isn't just one tablet. There are multiple different things that go into a HRT, some of which are safer than others. So the types of medication they were using are now out of date. So we've got a population which we wouldn't usually prescribe HRT to, with very high doses and with some of the more risky progesterones. So we're getting results there which are not transferable to modern day practice. So with breast cancer, what are the actual facts? We know it's a main fact for women choosing not to take HRT. We can't get around the fact that HRT does increase the risk of breast cancer, but it's to what degree does it increase your risk? We know that the dose of HRT that you take is important, and we know how long you take HRT for is important. So we should be trying to keep women on the lowest dose which is effective for the shortest duration of time that they need it for. And I think if I'm going to give you one take-home message from today, it's about lifestyle. Because we talk about risk with HRT, but actually lifestyle factors are far more important in your risk than HRT ever is. And I'm going to show you a graphic in a second that's going to illustrate that point for you. And also it's quite an interesting fact about breast cancer diagnosis. And it's shown that if women are diagnosed with breast cancer who are on HRT, their prognosis is actually better than women who are diagnosed with breast cancer off HRT. So overall, the risk of dying from breast cancer is no different if you're taking HRT or you're not. So that's quite an important factor. So I'm not going to interpret risk for you. You know, you're intelligent people, you can understand risk. This is the facts that we've got. This is MHRA have come out with a lot of data, and this is just some of it. So I mentioned that different HRTs give you different risk. So if you have a uterus, you need to take the combined HRT. That has slightly higher risk than pure estrogen HRT. But even then, you look at the risk at 5 years of taking HRT, it's 8 extra cases of breast cancer in 1,000 women, which is under 1%. So it's actually, yes, the risk is there, but it's a small risk in my view. And when you look at pure estrogen, the risks are lower. And this is, I think, the most important slide I'm going to show you. I share this with my patients in clinic a lot. It's an infographic that shows you the things that you can do in your life that will change your risk of breast cancer. So what it shows you, it takes 1,000 women for 5 years and says, how many will get breast cancer? So the background risk is 23. So 23 women will get breast cancer. Now the choices that you make in your life, whether it be medication or lifestyle, will affect that background risk. So if you are overweight, for example, it's the one at the bottom, 24 extra cases of breast cancer will occur because women are overweight. That's a huge increase in risk compared to any type of HRT that you will take. So all these factors are adaptable. So if you start exercising and lose weight and take HRT at the same time, overall your risk of breast cancer will actually go down, not up. So it's about trying to look at risk contextually and look at it for individual women, because you and your colleagues and your friends and family will have different risks and different lifestyles, so we can't generalize about risk. But I think this slide really brings it home that the choices you make in your lifestyle will be much more influential in terms of risk than HRT ever will be. And what's the risk of not taking HRT? Well, we know these are the benefits. We reduce the risk of osteoporosis and fractures. And that might not sound that risky, osteoporosis. You think, well, slightly brittle bone, okay. But if you look at an 80-year-old who has a fractured hip, the risk of dying from complications of that hip fracture are quite significant. If you develop a pneumonia or a clot in your lung after the fracture, these are risky things. So if you're able to reduce your risk of fracture in later life, then you will reduce risk of mortality. And there are studies that show that women who take HRT are much less likely to die than women who don't, in what's called all-cause mortality. So not taking breast cancer to one side, taking all reasons for dying, your risk of dying is lower if you have taken HRT. We know it reduces the risk of bowel cancer, and some local studies now, very interesting data, suggesting that there might be a reduction in the risk of dementia with HRT. And that's before we even get onto quality of life, which we've touched on already, but you can have dramatic improvements in women's quality of life from use of HRT. So overall, I think we have to weigh up the pros and cons of HRT on an individual basis. And us as clinicians should not make assumptions about what people's attitude to risk is. And so the picture there, is that a vase or two faces? I'll leave that to you to decide. So it's about a conversation between yourselves and the healthcare profession that you're seeing. And what you should expect is that healthcare professional to understand risks, understand benefits, and then have an informed discussion with you about risk. Thank you.
That's really helpful. Thank you so much. And I hope that will help some of you women out there to feel empowered to go and, seek some advice and ask for more specific individualised advice if that's where you're at in your sort of menopausal journey. So let us get into even more detail about HRT. So Tim did allude to the fact that there's lots of different HRT out there. You may have heard of terms such as bioidentical HRT, body identical HRT, compounded HRT. There's a lot of different terms being used. So I was hoping that maybe Paul could help us clarify this a bit further.
Yeah,
Thank
no
you.
problem. I think I saw a few nods, a few smiles there when that was mentioned. So now let's talk about hormone replacement. So we've heard a bit about risk, and I think it's important to consider that. But as Tim was talking about, this balance. So we've got a balance of what are the benefits. So let's look at the slide there. The ones in bold are the ones that I guess we would say are particular targets, and the one that people notice the most benefits from using estrogen replacement. And people will often talk about particularly hot flush symptoms, and they respond really well to hormone replacement. And it can be very quick and can change the intensity, frequency of them really very dramatically within a matter of weeks, and we'll come to that. The other thing that it it particularly seems to have an effect on, and whether this is related to the flushes themselves or whether it is just a symptom on its own, but sleep often gets a lot better in response to using estrogen. So I guess this bit of the talk is talking about all of the potential positives about helping with potentially some form of medication. We, as a group, are going to talk to you a lot about hormone replacement and I guess medicines that we can prescribe, but that's not the only thing. We've talked a little bit about lifestyle, we've talked about alternatives, and medication isn't what everyone wants to do to manage a set of symptoms. But I think we have to be open whenever we're having that conversation about benefits and risks and say, well, what's the most effective way of managing this collection of symptoms and helping someone who's going through this transition? And to be honest, estrogen is the thing that's going to make that the easiest to cope with. It is the most effective way of managing the symptoms. But as I say, it's not the only way. So we have to have some balance there with what we consider to help. But you can see it's quite a broad range of different symptoms. And I think we've mentioned the fact that almost any symptom that you particularly notice around this time of life and during the menopausal transition may well be related to the menopause. There's groups that we're sort of quite focused on that we know are typical symptoms, but everyone's experience can be quite different. And particularly if you notice a symptom around this time that then happens to improve, perhaps with some medication such as hormone replacement, then it's likely to have been menopause related. And the fact that it's improved is another benefit to taking that medication. So I mentioned it works. So how quickly does it work? Well, so this graph, it's the only graph in the presentation. So what we're trying to look at is the scale on the left there is the number of flushes someone's experiencing. And then along the bottom, we've got weeks. So from 0 to 12 in the weeks that the person might be taking a medication. And the top line, the white one, is what happens with someone taking nothing. So there is quite a placebo effect as you monitor people going through this experience. But if you then compare the people who are taking nothing to the different types of hormone replacement and the doses there, so the bigger the number, obviously the greater the estrogen replacement, you can see that the rate with which the flushes get better increases the higher the dose. And the little stars are where that becomes statistically significant. So there is mathematically a difference between the placebo and the group taking the medication. And you can see whatever the dose you take, it has an effect. But the higher the dose, the quicker it has an effect. And I guess the bigger the effect as well. The thing that I think is really important about seeing a graph like that is it gives you your answer about whether hormones are going to help with your particular hot flush symptoms really quite quickly. So if you're taking it, I guess what is the sort of average dose that someone might start on, within about a month you'll know whether it's having an effect. It won't be the total effect, you'll still continue to get some benefits till later. But yeah, so it does work quickly. And the reason that's important is we're talking about risks and benefits. You can get an answer about your benefits really quickly, and a lot of the risks tend to be quite long term. So we're talking about sort of 5 years of taking something, or 10 years of taking something, whereas your answer about, does this work for me, do I feel better, is really quite, not instant, but it is quite quick. So, we keep talking about hormones. So what are they? Why are they important? How do they work? So, a hormone is effectively a chemical messenger. It's a way of part of your body communicating with another part that's not directly linked. So it's not like nerves where you send an electrical signal to an organ to make it do something. We're using chemical messengers that are released in one part of the body and then influence the cells in another part. And they do that by binding different receptors, sort of locks and keys on the surface of a cell, or in the case of hormones, actually inside the cell. So it's changing the way that the apparatus inside the cell works so that the the code, the DNA within that cell, is read in a different way in response to that chemical messenger. So I'll turn something on, turn something off. And that tends to be how they work. And that's why hormones, the addition of them or the loss of them, can affect your whole body, because it's those hormones are spread throughout the whole body through the bloodstream. So, estrogen. This is the main one. So whenever we're thinking about the symptoms that we've talked about, it's to do with a reduction in estrogen. And then a lot of what we're talking about treatment-wise is about replacing that, giving it back, hopefully in the correct dose to alleviate the symptoms, but without getting side effects. And it's, again, balance again between benefits and side effects. But there are lots of different types of estrogen. And this is quite important with regards to that question about compounded hormone replacement, which looks to try and balance these three estrogens in particular, and then regulated bioidentical hormone replacement, which has a little bit more of a scientific basis and is a bit more supported by institutions like the British Menopause Society. It's a bit better regulated, there's more evidence to suggest that's the right thing to do. And that actually tends to be more related to the progesterone, which we'll come to. So estrogen. 3 different types. The main one that we focus on, and is the thing that is in most hormone replacement therapies, the ones that we would typically prescribe, is the estradiol, the one on the left there. So, made from cholesterol, produced predominantly by the ovary, but not exclusively. And the way your body does that is your brain signals to a gland at the base of your brain to tell that to release yet more different hormones that then influence the ovaries and make them produce the estrogen. This one, the estradiol, is the strongest acting. It does the most. It changes what the cells do, and it's the one that biologically will have the influence, which is why we replace it. The others are much, much weaker, and also quite a lot lower with regards to kind of concentrations in the bloodstream, and so become far less important. And we talk about how strong they are and how weak they are. That is to do with how well each of these hormones stick to the key within the cell, on the surface of the cell. And if you have one that is quite weak, it just doesn't hold on to the receptor very well. And so something like estradiol, which is a much stronger one, is much more likely to out-compete for that particular receptor. So it has a greater action, is more likely to influence that cell. Which means that the smaller, weaker ones are less important from the point of view of a biological action, so what you experience as a person with regards to what the hormones are doing. As I said, estrogen is something that is still produced by the ovaries, quite a lot weaker. We don't know much about its biology, what it's useful for, what it's needed for. The thing that's a bit of a concern is that it is noticed to be higher in certain adverse situations, so certain cancers it can be elevated in. And so because of that uncertainty about biologically what's it doing, and there doesn't appear to be a need for it, that's why people are a bit cautious about should we be adding that back in. So some of these compounded types of hormone replacement where you put all of those together, there's just that uncertainty about whether that's a good idea. And then the final one, the estriol, down there at the bottom, is very, very weak, really doesn't do anything as far as we can tell biologically, but is quite important and goes up quite high during pregnancy, and seems to be related to what causes labour to start. But again, this is not particularly relevant to using hormone replacement to help alleviate symptoms around perimenopause and menopause. So this is the reason that we're a bit uncertain about some of the biology behind compounded medications. Do we need to be balancing all of these, or should we just concentrate on the one that we know what it does, how it works, and seems to be the strongest of these type of estrogens? Do we need to balance these? We don't think so. What we do need to balance is the estrogen and the progesterone, if you need it. We'll come to that. There doesn't, as I said, appear to be a brilliant evidence base behind some of this. And For certain people who may have tried this or have spoken to people about using some of these compounded medications, there's quite a lot of drive to say, well, we should know what you need. So there's lots of testing. You might have had blood tests. There's some saliva tests that some people do to try and get an idea what's the balance that's right for you. Again, there doesn't appear to be lots of good evidence to support doing that because we don't really understand whether or not you need all the different component parts. And we see often the benefits of the estrogen replacement with just the one that's in the sort of standard type of prescriptions. The other thing that we worry about this particular compounded group of medicines is they're not regulated in the same way that things that can be prescribed by us that are in the British National Formulary. And because that regulation is not there, there's a bit of uncertainty about, if you purchase this or get a prescription from of one of these, is it the right thing for you? Is the prescription you might get today the same as what you would get in a couple of weeks' time? Uncertain, because there's not that regulation about the way they're manufactured. There's this degree of uncertainty. Whereas things that are regulated are regulated. So the MHRA, Medicines and Health Regulatory Authority, look at the way that these drugs are manufactured. So you know that every time you have a prescription for one particular hormone replacement, it's exactly the same. You get exactly the same thing in it. It's been tested, and we make sure that you're getting the same thing each time. And all of the evidence that we've talked about, and on the slides we talk about a risk of this and a risk of that, all of that data comes from using these regulated hormone replacements. And we know a little bit from studies like in the early 2000s. If we try and interpret one population to another without thinking about how those two populations differ, we sometimes get that wrong as a comparison. And so it makes people concerned that we should stick with the ones that we know and we understand and we've got that safety data for. So I talked about the regulated ones being a little bit more related to progesterone. Progesterone's important, but it's mostly during normal reproductive years prior to the menopause, more to do with the way that the menstrual cycle is kind of delivered, the fact that the lining of the womb thickens in preparation for a fertilised egg and then is shed as part of a period. That process is all regulated by progesterone. But beyond that, we are again uncertain how much need there is for progesterone for general health well-being. And so again, some of the compounded type of hormone replacements talk about, even in a situation where we wouldn't necessarily prescribe you progesterone, do you need it? And again, there doesn't seem to be good evidence that unless it's indicated, and the one indication we talked about is having a womb. So if you're going to take estrogen as part of hormone replacement, it has an effect at the lining of the womb. And if we don't balance that with some progesterone, the lining of the womb can become thickened, it can become unhealthy as well. And so we have to balance those two different things. This is where it comes on to, I guess, some of the sometimes confusion about hormone replacement and the different types. It comes on, do I need estrogen? Do I need estrogen and progesterone together? It is broadly that simple distinction between someone who has a womb and someone who hasn't. And if you've not had a hysterectomy and you still have a womb and the lining of the womb, it needs to be protected if you take hormone replacement as estrogen. But then how do you do that? Sometimes you take it in a form that is cyclical, a bit more like having periods, or like taking the combined pill. So it causes and prompts a bleed every month as a result of the way that it is being prescribed and the way you're taking it. Whereas certain other forms of hormone replacement, you take it all the time, and that doesn't prompt bleeding. Overall, it's probably safer to take progesterone all the time, and realistically the only reason we sometimes use it in that more cyclical fashion is so that during those early years of perimenopause, where ovarian function is still happening, where you're seeing those different fluctuations in hormone levels, we're trying to match what we give to what is happening naturally. And that's why cyclical can be important during that time in the perimenopause. But after a few years, it becomes less important, and we can switch across to taking something continuous, and therefore not having to have a bleed every month. So they're the main things with regards to the difference between compounded and then more regulated forms of bioidentical hormone replacement. A couple of last things to mention. We've talked about hormone replacement. There are basically broadly a few different ways to take your estrogen. One is take it as a tablet. I think that's probably the most common still form of taking hormone replacement. Is easy, people are used to taking oral medications usually, but it isn't for everyone, and there are some additional risks associated with those tablet forms. And we can counter some of those by using forms of hormones that you absorb through your skin, and that can be either patches, gels, sprays sometimes. Disadvantage in general terms of those is sometimes they're not absorbed quite so well, but they aren't associated with quite so many risks, and they can give you a hormone level that, because it's absorbed sort of more gently and more slowly through your skin, gives you a more even hormone level, and that sort of balance of hormones throughout the day can be quite important to help manage symptoms as well. So there's sort of pros and cons of different types of ways of taking the hormone replacement. And that's part of what we hope to guide you through if you want to take hormone replacement, as to what might suit you and the pros and cons of each of those different types. So yeah, I think they were all the things I was going to talk about with regards to the ways we take it. The one last point I wanted to make about this regulated type of hormone replacement, we've talked about progesterone, why we take it, why it's useful. There are benefits to taking some of the more natural type of progesterones. Something like called micronized progesterone is something that is much closer to the progesterone that you produce naturally from the ovaries. And because of that, it's better tolerated, you get less in the way of side effects. But it also seems to be slightly safer from the point of view of some of this risk that Tim was talking about with regards to blood clots that can be prompted by estrogen. Some of that's slightly less if you take progesterone in this format. And progesterone that's a bit more similar to natural progesterone doesn't seem to have the same effect on things like blood lipids and what your blood vessels do. So high blood pressure, cholesterol tests and things can sometimes be slightly better as a result of taking your hormone replacement in this type of format. So there's lots of different sort of subtle things to consider with when we're deciding what's the best thing, best way to take a form of hormone replacement. But I think we've all mentioned across the different bits we've spoken, it's all about balance. It's about trying to weigh up pros, cons, and then the benefits of certain forms of hormone replacement, disadvantages of certain forms, to make sure that it's the right choice. And as we've talked about, our job is to give you the information and explain pros and cons of each so that you are able to make a decision that's the right one for you.
That's incredibly helpful. Thank you so much, Paul. It's a lot of detail, a lot of food for thought, and I hope you've all found that really helpful. We are now hoping to open up for some questions. I know you've been handed out some cards. If you are happy to verbalise your question, I'll come around with a microphone. And if someone wants to ask a question but they don't feel confident to do so, just give me the card and then I can read it out. So I'm just going to go and get this microphone.
Would it help if people put their hands up?
Yeah. So I'm just going to take myself down here and I'll ask you questions from down the floor.
Okay, well done, Susan.
And I did just want to point out the fact that we've got our amazing illustrator here.
Yeah.
Because you've been taking note of what she's been doing in the background. It's absolutely brilliant.
Yeah.
Lots of
Really good. Look at me.
Sure. I've heard and you've discussed that my risk of having a heart attack or a stroke increases after menopause. This is a two-parter. How soon after menopause do our arteries become noticeably more hardened with plaque? I'm 53, so 3 years post-menopause. Is it too late to turn back the clock in this regard? I am on HRT.
Would you like to?
Well, we know that the main benefits from taking HRT are achieved if it's taken around the time of your menopause. If it's left to many years later, then we don't think the benefits are as good. And in fact, there's some evidence that actually your risk of heart disease can increase with HRT if it's taken suddenly in your 60s or 70s. We do think there's, as Paul alluded to, there's influences in your lipids and cholesterol, and we think that what happens is that women's risk of heart disease and stroke catches up with men's after the menopause, and we think it's because of the way that the lipids and the cholesterol changes to a more male form of fats. And what HRT does is prevent that change from happening. And so I don't think it's ever too late to take HRT, and risk happens over many years. And of course, many people have heart disease and stroke many years after the menopause. It's not imminent. So I would say that certainly if you're in your 50s and you want to start HRT, you are able to influence that risk at that stage, I would say. I mean, Paul, do you think?
Yeah, no, I'd agree with that. There is so the reason there's a difference, we think, is as we all age, our risk of developing atherosclerotic plaques increases, and they grow very slowly in vessels, and the rate with which they grow goes up when your estrogen drops, so as you become menopausal, which is why the risk sort of catches up with the risk for men. But as those plaques get bigger and bigger, at a point in the future, they become quite unstable, and if you add estrogen in that circumstance, when it can have an influence on how sticky the blood is, it can have a negative impact. So those atherosclerotic plaques are more likely then to cause a blood clot, block off an artery and cause something like a heart attack, a stroke. But if you do it earlier, it's basically countering the rate of progression. So the estrogen has a positive impact, and I guess the simple and easy answer to your question is no, it isn't too late to turn back the clock or have an influence on how things change in that first 10 years after menopause. So yes, it changes.
We talk about the cardiovascular window of opportunity, don't we, which is the first 10 years after the menopause, and you're well within that if you're only 3 years post, so definitely never too late. And of course lifestyle factors can have a big influence as well. So an individual woman's risk of heart disease will be affected by her genetics, which obviously you can't change your genetics, but you can change your eating habits, your smoking history, your weight, your exercise. All of those things have a role to play. But no, you're well within that window of opportunity.
Excellent, thank you. And I saw a question over here.
Hi, thank you very much for such a really great and informative talk. I am a clinical specialist in mental health, and I was just really interested in hearing a bit more about the mental health impact in the menopause, I guess especially in light of sort of things that are kind of coming out in the media at the moment.
Yeah. So I think this comes back to what we've talked about several times in the course, is the fact that there are estrogen receptors in our brains as well, and so those declining levels are going to have an impact on the way that our brain functions too. And I think it's really interesting because actually I do know you, Katie, don't know, we've met before, and we had conversations about the fact that actually women's suicide risk increases at the age of 48, which is the time that a lot of women go through the menopause and the perimenopause, and the positive impact that starting HRT can have. And I also just thought I'd lead on from your question just to say that, well, actually, before I get onto that, I was just going to mention that I think sort of historically, in terms of our hormones, there's been a bit of a mind-body split. So the mind has been the remit of the psychiatrists, and they've got their kind of bag of drugs that they use to treat the psychiatric issues. And then the hormones have been the remit of the gynaecologist and the endocrinologist, and they, have their their view of looking at it, which excluding you two, obviously, they don't always think about maybe the cognitive effects and the mind and the mental health side of things. I think it's really important to look at as a woman as a whole during this time. But I think historically, obviously, that's been the case. But it's really interesting because we've met, haven't we, Katie? Because you are key in the crisis team in terms of rolling out something called the MENO-D score, which is a menopause depression score, so that you're trying to identify those women who are in a mental health crisis and sort of differentiating those who've got clinical depression from those who've got menopausal depression. And menopausal depression tends to present in kind of anger, rage, also variability of your mood as well. And then you're going to be working with some of the local GPs locally, like our practice and your practice as well, in terms of getting the GPs to prescribe HRT promptly in these situations, so that women have got their hormones replaced and helping their minds from that perspective. So I think it's really exciting what you're doing and really, really needed. So yeah, well done.
If a woman's very happy with her HRT, bobbing along 5 years, 10 years, do you have an issue it going beyond, 15, 20? Is there a reason to, if everything sort of stays the same?
So, yeah. So what we would always recommend is that women have an annual review about their menopause symptoms and their HRT, because the needs will change, and doses can come down, and prescriptions can alter. Risk factors can also change, so the risk-benefit ratio will alter as you get older. One thing that I found quite frustrating, I'm sure everyone else does, is people drawing red lines and saying you must stop HRT at 55 or 60, or we shouldn't have red lines. It's a discussion between a clinician and a woman. And it's about regularly reassessing risks and benefits and deciding, actually, are the benefits still outweighing the risks? And if it is, then you continue. But it's also quite important that we don't just blindly take HRT till we're 120. You've got to balance it all the time. But it's the problem with the red lines of people putting rules in. Oh, you can have it for 5 years or 6 years, and then you must stop. These arbitrary rules are not really evidence-based. They're not very practical.
I'd agree, Tim. I don't think there's any arbitrary limit, and in fact the BMS now says that there should be no arbitrary limit. Again, it needs to be individualised to that woman. And I'm sure you have, Hannah, too, got patients well into their 70s or 80s. I've got one lady who's 88 who's still very happy on HRT. She's tried off it several times, and she feels that her quality of life just dips so much that she stays on it. And there is some evidence as well that cardiovascular risk and stroke risk do increase in the first year after stopping HRT. So for a woman that's particularly high risk for stroke or heart attack, sometimes they choose to stay on it indefinitely. But that's, again, a discussion that needs to be had year on year with that woman. And I think it is really important, as you say, to follow up quite regularly.
Yeah.
We've got time for 2 more questions.
Hello, just wanted to say as well, it's been so informative, really, really good. I thought I knew a lot about it, but you've been so good. 2 questions, if you don't mind, just quick ones. One is, I'm on HRT patches, Everil Conti, the progesterone and estrogen, but I'm low on estrogen, so could I just take estrogen gel as well as to up the estrogen without more progesterone?
So what's the so what are you taking at the moment?
Everil Conti patches, their combination.
So what's sometimes difficult when you try and take something, so the Everil Conti has, it's balanced. The amount of estrogen and progesterone is specifically designed for that combination. There are circumstances where the estrogen in what you're taking isn't quite enough for you, so you need some more. So topping things up seems to make sense. Well, I need a higher dose, so I'll take some more. The thing we find difficult is knowing whether or not the progesterone that was balanced for the amount of estrogen that's in the Everell Conti patch. Does that cover for the extra? And we don't know, if we're completely honest. And there is a concern that if you don't balance those two things, that you are at greater risk of the lining of the womb becoming unhealthy. And so in those circumstances, it's often better to think about taking the progesterone in a different way. And often the micronized progesterone can be quite a neat way of doing that, because you separate the two things. So you can then adjust your estrogen as much as you need to for your symptoms, and then take the progesterone as a separate thing.
Okay, thank you. And one very quick one. I'm on testosterone very recently, and it had helped with a few things, but I've since had a couple of migraines and acne and also breast pain. Would the breast pain be linked to taking that, do you think? No lumps or anything, just sharp pains.
To the testosterone?
Yeah.
It's unlikely to be, but you've changed a few things, I guess, from what it sounds like.
Just taking testosterone. I've been on the patches for about 5 or 6 years.
Okay. So usually those type of side effects, so breast pain type side effects, tend to relate to, somewhat inconveniently, either too much estrogen or not enough. And they can be, it's usually perhaps too much in the way of estrogen as a side effect, often. But again, it's sometimes difficult to balance that. It depends a little bit on when you started or changed anything, when you noticed the symptoms. So that can be quite specific, and probably quite specific to you. But it's not, breast pain itself is not usually a side effect of testosterone.
Acne definitely can be.
Yeah.
Acne is a very common side effect of testosterone. Yes. And it often does settle in time, but it can definitely be triggered. Yeah. Migraines as well can be with testosterone, and also with estrogen. If you don't start it slowly, it can be an initiation side effect. But you've been on your estrogen at a steady dose for a long time, so it might be the testosterone.
And it's also, that's why we like to do a blood test just after somebody's been started on testosterone. Yeah, so it probably is you're getting too much. Yeah. The dose needs to be changed.
I think we'll just end with this last question, because I'm getting away. There's another event here after us. But I've just had this question handed to me, which I think is important, because it's around women who are at the age of 60. And the question is, can I start taking HRT or anything else that would benefit me now, post 60? Or is it too late? Never been offered HRT or prescribed anything, because I guess there's going to be a cohort of women who think, have I missed out? Should I have maybe been on something? Is it too late for me now at this age? And there's a whole load of symptoms listed here that could potentially be menopausal, like vaginal dryness, and extremely weak, tired, muscle tone reduced, joint pains, feeling very cold. Does any of you want to take this question on to explore what options there are for those over the age of 60?
Yeah, I don't think it's ever too late. Again, it's all about that individual and the symptoms you're getting, the severity of those. And it's not a no to starting HRT after 60, but the risk profile will be a little bit different, and you'd want to do it very gradually, because if you suddenly start a large dose of estrogen, as we've said, it can destabilise any cardiovascular clots that you may have developed. But again, your lifestyle will be important, your background cardiovascular risk, your background breast cancer risk. But there are a lot of benefits of starting HRT still in your 60s. But if you chose that HRT wasn't for you, then of course there are other non-HRT medications and lifestyle factors and alternative therapies that could be helpful. So definitely not a no, but it would need consideration.
Yeah, we'd need to explore it.
And it's important always to balance your quality of life with some of the potential risks that might increase in later life.
And I think the other thing to just mention in this age group is often, we might need to consider using topical estrogen or vaginal estrogen. It's often 10 years after the last period that we start seeing the genitourinary symptoms. So women might present with recurrent UTIs, and actually using some topical estrogen can be extremely helpful at this stage in a woman's life, and that's actually even started being sold over the counter since January this year. And it's a very safe way to treat those symptoms, and can be really life-changing for a lot of women. Right. Thank you so much, everyone, for coming.
Thank you.